Hello, and welcome to Understanding and Improving Post-Intensive Care Syndrome, a Rehabilitation Perspective. Myself, Michael Friedman, will be the webinar chair. We'll have presentations by Dale Needham, Jennifer Zaney, and Megan Hosey. This program is presented by the Johns Hopkins at ICU Rehab Program and at Hopkins AMP. Both are key initiatives that have been part of developing our systematic approach to hospital immobility and intensive care rehabilitation in the hospital. As we move through this webinar, you will be able to submit questions. Please submit them at any time. You may type your question in the question and answer feature found at the bottom of your screen. You'll see the icon posted here. You may submit your questions at any time throughout this webinar. Questions will be answered after the presentations conclude in a panel-like setting. Panelists may not have time to answer all of the submitted questions, but we'll do our best to answer the frequently asked questions. Also note, you can ask questions by posting them on our Twitter feeds at ICU Rehab and at Hopkins AMP. To give context to post-intensive care syndrome, it'd be remiss not to talk about the current COVID-19 pandemic. As we've all experienced, severely ill inpatients commonly experience post-hospital syndrome or post-intensive care syndrome for critical illness survivors even prior to COVID-19. But it's clearly become a hot topic as we face more and more ill patients coming through our ICUs. Post-intensive care syndrome is typically characterized by impaired strength and physical ability, worsened mood and anxiety, and other mentation challenges, difficulties with thinking and memory, as well as leads to many increased uses of health care resources, resulting in increases in total cost of care. This clearly is a very important topic for us to address and consider how we can best move forward to address the concerns of post-hospital syndrome and post-intensive care syndrome. So prior to COVID-19, the rehabilitation continuum would look very much like this in most hospitals around the world. Specifically at Johns Hopkins, this is our approach. We have a strong rehabilitation consultation service, which provides consultation for many patients and true intervention for fewer. We have a critical care rehabilitation program focused in our ICUs to provide mobilization early and often, address activities of daily living, as well as swallow concerns, teamed with the respiratory therapy, the medical team, as well as nursing. And we have a very strong interdisciplinary activity and mobility program to maximize mobility throughout the day and really keeping in line this concept of what the 24-hour clock should look like, being upright for daytime activities and at rest in the evening. This is supported by a post-acute network of inpatient rehabilitation facilities. These could be skilled nursing facilities, these could be acute rehabilitation centers, or in some places around the world, these are units or floors within acute hospitals focused on the aftercare of patients past their acute phase of illness. We also have home care as well as outpatient rehabilitation. When addressing PICS, typically we haven't necessarily had a coordinated approach to manage all the transitions that occur both within the hospital itself as well as each junction point where rehabilitation teams are changing and having handoffs, plus having communication with primary care physicians, specialists, and other providers. So as COVID-19 started to materialize, we started to see elements that really are a recipe for not just physical impairment, but overall functional impairment, though most recognized in the popular press are probably those with physical as well as delirium. So I split these into two categories. Treatment elements, so sedation practices, mechanical ventilation, oxygen support, bed rest, increased lengths of stay are all elements that drive post-intensive care syndrome. In addition to those elements, we added components tied to either the response to COVID-19 or infection control of social isolation, PPE policies for conservation, reduction in clinician access, redeployed nurses as well as other providers, and also access to mobilization equipment all declined. So despite WHO guidelines that recommended management of COVID-19, we recognized to mobilize patients, we recognized that this was a really difficult environment. And this really exacerbated things many of us already knew about post-intensive care syndrome. It just really became louder and more visible with the sheer number of patients coming into the door and the sheer number of patients who are a percentage of ICU care within a hospital. So as COVID-19 continued to progress, we found an altered health system. We found that we moved from a rehabilitation consultation service to really an intervention force, where more and more patients were being rehabilitated in place in the hospital, as opposed to moving throughout the continuum of care. This was for good reason, as a number of inpatient rehabilitation facilities or long-term care facilities had reduced access to prevent spread of the disease. Furthermore, a number of ambulatory or outpatient rehabilitation settings were closed off to the public, meaning that more impaired patients were going to be sent into the home care environment. Home care rehabilitation exists in some parts of the world in very differing levels. In the United States, home care was able to get going, but did face challenges with quarantines, refusal of care, and concerns about healthcare workers going into the home, concerned about spread of illness. We also saw an increase in critical care rehabilitation. The sheer number of patients eligible, the number of ICUs, as well as we saw maintenance of our activity and mobility promotion, even more important since we couldn't really move patients oftentimes outside of the room or expose them to visitors or other cognitive stimuli. We had to get creative in how we would orient them to time and space and place. And so as you can consider our COVID-19 response, this is the exact time to now develop your PICS solution. Oftentimes prior to COVID-19, there was a tremendous barriers in setting up PICS. We would often lose patients as they transitioned through the system. They were often not picked up on the connection between the different impairments they might have in coordinated care, but were actually treated a la carte, perhaps by a physical therapist for physical impairment, a psychiatrist, partially managed by primary care. So as we came forward with COVID-19, there were many things that came into place to now coordinate this effort and overcome previous barriers to care. Number one, we have a tremendous opportunity to drive health system redesign. Things that we never thought possible or have taken years in the past have now changed and operationally realized within several weeks. Secondly, there was a focus on COVID-19 survivorship that has really been shown in the popular press. Whenever something comes from the popular press or from the patients themselves, this isn't necessarily an issue that just was our own passion, but is something that really is out there as a need that needs to be addressed as a priority for your health system or hospital. Health system resources that might have been split across a number of priority populations, from stroke to surgical interventions to chronic diseases like CHF or COPD, have now been mobilized to address patients with ICU syndromes, or in this case, COVID. Managing transitions of care, leaving the hospital, going to an inpatient rehab facility or home. Access to care, assuring patients had access to appointments via telemedicine, phone, technologies, assuring that they got the follow-up care they needed, and coordination of care of multiple disciplines getting together and communicating, as well as assuring patients had that care coordinated, much like we would see in cancer survivorship. Additionally, on top of this, we saw hyper-advanced technology solutions that came to market fairly quickly. We've been talking about telemedicine, remote patient monitoring as solutions, as well as quickly designing our electronic medical records to develop these workflows. Things that might have taken years in regulation or standing up to access as both providers and patients all of a sudden happened in weeks and months. And all of these things together lived on a foundation or environment of increased interdisciplinary collaboration and communication. The combination of resources, prioritization, and technology has created a foundation where something challenged, like a PICS service line, clinic, or solution, which requires multiple providers addressing multiple needs of the impairment in a coordinated fashion, would have historically been challenging. But now is the time for us to take advantage of this moment and push our solutions forward. Today, we're going to start you off with giving you an overview of PICS by Dr. Dale Needham. This will be followed by Jennifer Zaney on physical impairment, and then Megan Hosey, who will do cognitive and psychological aspects of care. These are the three core components that we think are important for you to start your journey to your PICS solution. Remember, as we move forward the next stage of the presentation, Dr. Dale Needham's component, please type in your question during the program. You're welcome to answer any questions you might have had for my section as well. We'll try to get to everything we can. We will record the frequently asked questions and, if possible, respond later. Also, feel free during the presentation to comment on our social media platforms at ICU Rehab and at Hopkins AMP. Thank you and enjoy the presentation.
I'm going to speak about post-intensive care syndrome and care in the ICU in today's lecture. In terms of disclosures, I am a principal investigator in an NIH-funded multi-site randomized trial, and as part of that trial, we have support from Rec Medical Devices and Baxter, but this will not influence today's presentation. So this term post-intensive care syndrome is about a decade old, and it was created by a multidisciplinary stakeholder conference from the Society of Critical Care Medicine. And PICS is defined as new or worsening impairments in physical, cognitive, or mental health that arise after the ICU and persist beyond acute care hospitalization. This is generally applied to survivors as seen in the right side of the figure, but this can also be applied to family members, PICS-F, as talked about on the left side of the figure. So I'm going to take us through aspects of post-intensive care syndrome. In terms of physical, one of the important physical aspects is neuromuscular abnormalities. This can include contractures and also can include muscle weakness. And among muscle weakness, one of the important causes is critical illness neuromyopathy that sometimes is referred to as critical illness polyneuropathy and critical illness myopathy. But where I'm going to focus a little bit more time is on disuse atrophy associated with bed rest. So there's an important landmark study published in JAMA that looked at patients' leg muscle wasting through the use of ultrasound, biopsy with histology, and biochemical analyses of protein balance. So in mechanically ventilated patients that were expected to survive and stay in the ICU for at least 7 days, these modalities were used to look at muscle wasting. So here is the figure of patients' ultrasound of their quadriceps cross-sectional muscle area. So over the first 10 days of the study, patients lost on average about 18% of their cross-sectional area. And important to note that this started early. In patients with respiratory failure on a ventilator and at least one other organ failure, patients lost almost 10% of their muscle mass within the first 3 days. For those that are less keen on muscle ultrasound analysis, they also performed biopsy and had relatively similar findings with about a 10% decrease in cross-sectional area based on analysis of biopsies using histology. They also noticed that about 54% of patients had evidence of myofibronecrosis on those biopsies. And then finally, they did biochemical analyses of protein breakdown, demonstrating that over the first 7 days, there was an increase in protein breakdown, a decrease in synthesis, and this net catabolism was independent of patients' nutritional intake. So no matter how the muscle analyses were done, there's evidence of early and ongoing muscle wasting in critically ill patients on ventilators. That study did not actually evaluate the implications of the muscle wasting, the weakness that we expect patients to have. So I'm going to transition to a study that my group did looking at 222 ARDS survivors recruited from 13 ICUs at 4 hospitals in Baltimore. This study eventually followed these survivors all the way out to 5 years after their ICU stay, but I'm going to focus on just the first 4 of the longitudinal assessments over the first 2 years. So this figure shows patients with ICU-acquired muscle weakness, so weak arm and legs based on physical examination. Those with ICU-acquired weakness are in the dotted lines. Those without ICU-acquired weakness are in the solid lines. And this looks at patients' assessments at 3, 6, 12, and 24 months. So in the top left, not surprisingly, we see that patients with weak arms and legs also have weakness when measured with grip strength. The bottom left shows us that patients' respiratory muscles are also weaker in those that have weak arms and legs. The 2 panels on the right represent the first studies that actually demonstrated that muscle weakness is associated with impaired physical functioning. And that's impairment when measured by an objective performance-based 6-minute walk test, and impairment when reported based on the SF-36, the self-reported physical function domain of the SF-36. And the SF-36 is the only one of these analyses, of course, that we can use to estimate patients' baseline function. And here you can see that the baseline on the y-axis is dramatically better than what we see even over the first 2 years of follow-up. So patients with and without ICU-acquired weakness have large and sustained decreases in their physical functioning based on self-report. So this muscle wasting leads to muscle weakness that really matters in terms of patients' physical functioning. And in the same study, we wanted to understand what variables are associated with these relative decreases in muscle strength over time. And all the variables on the bottom part of the figure we thought might be associated. In fact, none of them had a significant and consistent association with muscle weakness over 2-year follow-up. But after we adjusted for all of these variables, in fact, there were 2 that were independently associated with these decreases in muscle strength. The first was age. For each decade that patients were older, there were large relative decreases in muscle strength compared to younger patients. That's not a modifiable risk factor, and some of that weakness might have been pre-existing. But the second of these variables that was independently associated is the duration of bed rest, and this may be a modifiable risk factor. So this may be what we can address during patients' ICU stay and perhaps decrease long-lasting muscle weakness and the complications. So it's more than just muscle weakness. This looks at other measures of physical functioning, including activities of daily living, as listed here. We know from numerous studies that ICU survivors frequently have impairments in their activities of daily living. Even these basic activities are commonly impaired and long-lasting even at 1-year follow-up. And what about instrumental activities of daily living as listed here? Again, it's very common to have long-lasting impairments. In fact, the majority of ICU survivors have impairments 1 year later. And some people may say, well, some of these impairments may be pre-existing before patients have the ICU stay. But again, that ICAP study that we completed from the Baltimore area demonstrated that 2/3 of the cohort had new impairments. Their impairments in instrumental activities of daily living were not in place before their ICU stay. So 2/3 had at least one new impairment in an instrumental activity of daily living. Importantly, this study also demonstrated that depressive symptoms were an independent risk factor for patients having subsequent physical impairment. So it demonstrates how the head bone is connected to the body bone. And here's a recent systematic review that we conducted looking at IADLs among all studies that evaluated this outcome after critical illness. So you may want to check that out. And then finally, the most common measure of physical functioning might be the 6-minute walk test in studies of ICU survivors. So this was a recent meta-analysis where we found 26 publications. And as graphed here, we showed that all time points over 5-year follow-up, the survivors had scores or walk distances that were lower than population norms. And encouragingly, there at least was an increase between 6 and 12 months, but still they remained below population norms all the way up to 5-year follow-up. In terms of prevention and management, it's important to think about glycemic control and using the lowest dose of corticosteroids and neuromuscular blockers for the shortest period possible. But perhaps the largest body of evidence for reducing this kind of muscle weakness and decreasing the duration of mechanical ventilation is early rehabilitation in the ICU settings. There's a large body of evidence around this, and there is a conditional recommendation supporting this as part of the Society of Critical Care Medicine's PADIS guidelines published in 2018. I provide this paper here because it's a free full text article, and it summarizes in narrative form some of the benefits that have been demonstrated in randomized trials in terms of early ICU rehabilitation: improved strength, improved independent walking, improved number of days in which patients were alive and outside of the hospital. So moving on then, I'm going to transition into the mental health aspects of post-intensive care syndrome. We've conducted a series of meta-analyses of studies done in critical illness survivors. This is a study that we conducted in patients, in studies that evaluated patients with depressive symptoms. And you can see here that, again, the prevalences are very high. In fact, in our Baltimore-based study, the 2-year cumulative incidence was 40%. And with looking at individual data with the same patients measured over time, there is no evidence of improvement in these symptoms over the first year of follow-up. Patients that are most at risk of depressive symptoms after the ICU are those with pre-existing psychiatric morbidity before the ICU, or those that are demonstrated any type of psychiatric symptom during their hospital stay. So we need to pay close attention to that while patients are hospitalized, and recognize that may be a signal that patients may have long-term problems, and we may need to help set up additional mental health help for them before they're discharged from hospital. And in fact, in terms of protective factors, although it's still exploratory, there's some signal of benefit that physical rehabilitation after discharge may improve depressive symptoms. So stay tuned for more research there. In terms of post-traumatic stress disorder, again, we performed another meta-analysis here showing that approximately 1 in 4 ICU survivors may have clinically important symptoms of PTSD over the first year of follow-up. And in some patients, these can be long-lasting symptoms many years after the ICU stay. In terms of risk factors, we need to be recognizing that sedation and patients endorsing having traumatic memories or memories of events that never happened in the ICU, so memories of them being harmed in the ICU, these are risk factors for patients that would have prolonged post-traumatic stress disorder. So we need to be thinking about limiting sedation, trying to limit the durations of delirium in the ICU that may possibly reduce post-traumatic stress disorder. We do also want to think about ICU diaries. These diaries written by family members and clinicians in the ICU in one randomized controlled trial has been demonstrated to substantially reduce post-traumatic stress disorder. But interestingly, a multi-site blinded trial conducted in France among all patients couldn't demonstrate a benefit, unlike the prior randomized trial. However, importantly, the diary was not reviewed with patients or families in a formal meeting after hospital discharge, as had occurred in the prior study, and the patients read the diary less frequently than in the prior study. So some of those things may have resulted in differences in the study's findings, and they didn't find any differences in family outcomes in this specific study. But for people who are interested in ICU diaries, I highly recommend this website, icu-diary.org. There's lots of helpful resources there, as well as synthesis of the existing evidence. So finally, I want to talk about the third part of post-intensive care syndrome around cognition. Particularly impaired after the ICU are things like executive function, the ability to plan and organize tasks, as well as memory and language. So we see here from some of these studies that there are very high instances or prevalences of cognitive impairment, only almost half of patients at 1 year follow-up, with no important changes, unfortunately, between 1 and 2 year follow-up. And these findings are not just from ARDS survivors, I also show findings there from the MICU and general ICU survivors. And here's a landmark study that enrolled a large group of patients with respiratory failure or shock who had no evidence of cognitive impairment before the ICU, and then had standardized cognitive testing after the ICU, with 1/4 of patients having test scores consistent with mild Alzheimer's disease. And the most important modifiable risk factor for that cognitive impairment is the duration of delirium after the ICU. And potential risk factors for cognitive impairment include that duration of delirium, hypoxemia, hypotension, hypoglycemia in the ICU, as well as patients with lower pre-existing cognitive reserve. Management recommendations here will include reducing the duration of delirium and recognizing again that the head bone is connected to the body bone. So in fact, it's been shown that early occupational and physical therapy in the ICU can reduce the duration of delirium substantially. So we should be thinking about that as well. Then all of these aspects of PICS, importantly, have very major impacts on patients' return to work and healthcare utilization. In a study of about 500 survivors from the ARDS network from 41 hospitals across the United States, our group demonstrated that more than half of the survivors required physical rehabilitation interventions, and about half of them that were previously employed before the ICU were not working a year later, with 3/4 of them attributing that unemployment to their health-related problems. And in fact, there's a very large body of return to work after critical illness. This meta-analysis evaluated 52 studies with more than 10,000 previously employed ICU survivors, demonstrating that only 1/3 of ICU survivors had returned to work at 1 to 3 month follow-up, and 2/3 had returned to work over 5-year follow-up, with the latter meaning 1/3 were not working. And in fact, again, our study from Baltimore showed that 1/3 of ARDS survivors had never returned to work at over 5-year follow-up longitudinally. And even those that are returning to work, some of them have returned to work and then lose their jobs. Some of them have a change in occupation or have to take jobs with lower incomes, resulting in large lost earnings. So clearly there's major issues and major needs for improvement. We need to watch out for return to work and think about occupational rehabilitation. So to wrap things up then, there's a large legacy of critical illness called post-intensive care syndrome with impaired physical, cognitive, and/or mental health outcomes. In terms of evidence-based interventions, we need to be thinking about minimizing sedation and delirium, instituting early rehabilitation, perhaps the use of ICU diaries, and then after the ICU, continuing with rehabilitation and self-help for these patients. For people that want to get more information, I would welcome them to look at our website here from the Outcomes After Critical Illness and Surgery group. For people that want a monthly update on these sorts of topics, my assistant, Kim Madison, at the email address here can send out a monthly email to you that goes to about 3,000 people from around the world to understand the latest research and publications. Also, I want to say the whole way that our field is going to move forward is large-scale learning networks and collaboration. So this is just one of them. I showed you the ICUdiary.org. Here's a mobilization.org, mobilization-network.org website for people that want a daily update on ICU rehabilitation and post-intensive care syndrome. I'd invite you to join Twitter and follow the 2 addresses there. And then we've also created, free of charge for healthcare professionals, a Facebook-like electronic platform with no advertising, no commercial affiliation, that allows people to interact directly with each other. So again, my assistant Kim can give you a free membership in that, and you can post messages and people can respond as well. And then finally, for people that want more detailed information, we're doing a 3-day ICU rehabilitation conference, the 9th annual year at Johns Hopkins. And we have a 1-day pre-conference this year dedicated to ICU follow-up clinics. There's going to be tremendous interest in ICU follow-up clinics after the COVID pandemic. So we invite you to come for the ICU follow-up pre-conference on November 5th and to stay for the entire main conference on November 6th and 7th. We'll cover topics like ICU rehabilitation, post-intensive care syndrome, pain, sedation, and delirium. So join us for that. And with that, I thank you very much for your attention, and I look forward to a future question and answer with you. Thank you, and goodbye.
Thank you, Dr. Needham. As we move on past the overview of PICS, now we welcome Dr. Jennifer Zaney, who will review the physical impairment component of post-intensive care syndrome, followed by Dr. Megan Hosey. As a reminder, please submit your questions. You can submit questions previously that you might have had for Dr. Dale Needham, or as you have them during Dr. Jennifer Zaney's presentation. Please, as a reminder, feel free to comment or retweet any of the references or any questions you might have at ICU Rehab or at Hopkins AMP. Again, thank you for your participation and all your engagement in sending questions. And now I welcome Dr. Jennifer Zaney.
Hi, my name is Jennifer Zaney. I'm a physical therapist here at Johns Hopkins. I've previously worked extensively in our medical intensive care unit on our early rehab and mobility project. However, I'm now actually in our outpatient department where I continue to work with patients who are medically complex and those patients who are in post-intensive care. Dr. Needham has laid out many of the known long-term challenges that our PICS patients face. And I'm really going to focus this session on the role that physical rehabilitation plays in the management of post-intensive care syndrome. So in the framework of post-intensive care syndrome, I'm mainly going to focus on the known physical impairments, especially how it relates to pulmonary, neuromuscular, and physical function, and the intervention strategies best to manage these challenges. The International Classification of Functioning Disability and Health, or the ICF model, is a framework for describing and organizing information on a person's function and disability. The ICF model serves as a good framework for characterizing the nature of physical problems associated with post-intensive care syndrome in regards to impairments in body function and structure, activity and tasks, and participation. Our survivors of critical illness often experience impairment in all three of these domains. So when viewing PICS through the ICF model, there are many known impairments in body function and structures. These include muscle weakness with known deficits in hand grip dynametry, lower extremity muscle strength, as well as the presence of ICU-acquired weakness. Patients also experience endurance and balance impairments and have known pulmonary compromise that may include decreased inspiratory muscle strength, impaired pulmonary function, and impaired cough. Speech and swallowing difficulties are also commonly seen. Activity impairments represent the functional level of the individual. Testing has demonstrated that the 6-minute walk test is decreased in PICS patients in every study, regardless of the need for mechanical ventilation or diagnosis. The reductions are often long-lasting and are possibly permanent. Gait speed, as measured by a 4-meter walk test, is also reduced in many patients. Participation represents the functioning as a person as a member of society. Commonly seen impairments include impaired mobility in the home and community, a limited ability to return to their previous roles in their job, in school, or in home, a difficulty in returning to driving, impaired ADLs or IADLs, and unable to return to previous hobbies or recreational activities. One must also consider, when looking at a patient's recovery process and their level of ability or disability, what other environmental or personal factors also play a factor. So we've put much emphasis on providing early mobilization and rehabilitation to our intensive care patients. And while this is recognized as safe, feasible, and beneficial in potentially preventing the long-term sequelae of post-intensive care syndrome, we need to recognize that post-intensive care patients still may need a full continuum of rehabilitation care to optimize their ability to return to pre-morbid level of function. This may include care that transitions from the ICU and acute care settings into inpatient rehab, followed by home care, as well as outpatient rehab services, with the goal of returning to independent self-management and community wellness activities. Preventing PICS symptoms from the ICU admission is more effective than providing the intensive rehab following ICU and hospital discharge. Early rehab in the ICU is essential for reducing the impairments associated with post-intensive care syndrome. So when I say early, I really talk about those mobilization and activities that can be done once the patient has been stabilized from a hemodynamic and respiratory standpoint. And oftentimes this occurs within the first 24 to 48 hours of an ICU stay. But despite the numerous studies that demonstrate safety and feasibility of early mobilization of ICU patients, there are still many barriers as to why this does not occur on a more regular basis. These barriers continue to include the use of sedation, the lack of knowledge in regards to the benefits of early mobilization, as well as the long-term sequelae outcomes of patients with PICS, and poor interdisciplinary collaboration and communication. In 2018, the Society of Critical Care Medicine published the practice guidelines for prevention and management of pain, agitation, sedation, delirium, immobility, and sleep disruption for the adult ICU patient to provide a roadmap for developing integrated, evidence-based, and patient-centered protocols. Their guidelines state that rehabilitation that's commenced within the first few days of mechanical ventilation is safe, feasible, and beneficial. And serious safety events are extremely rare. Mobilization of patients who are mechanically ventilated with an endotracheal tube is not an indication for mobilization. And waiting up to 5 days for the patient to be ready to begin therapy may actually worsen a patient's recovery. So really, the early intervention as soon as a patient is stabilized is the going recommendation for our patients. So in discussing early rehabilitation in the ICU, we know that functional mobility activities that are delivered by a nurse, a PT, and or an OT that are started at ICU admission really are the ones that have the most significant benefit, and that early rehab improves the short-term, is known to improve short-term outcomes in patients with critical illness, but there still is limited evidence to demonstrate long-term improvement in these impairments to date. So when we start talking about what are the interventions that we are doing in the ICU early on, we're really, the main focus in the beginning is just focusing on function. This includes being out of bed as much as possible, trying to start having the patient performing ADLs or as a therapeutic means participating in ADL activities as soon as possible. Strength training can be done in the ICU through use of resistance training, bands or weights, through body weight activities, endurance activities in regards to walking, in-bed cycle ergometry, and interactive videos have all been strategies that have been used to work with patients with endurance piece. Other interventions includes balance training. There may be the need for more pulmonary interventions, airway clearances if it's indicated, the use of inspiratory muscle training to address respiratory musculature weakness. There may be speech and cognitive interventions, since we know that many of our patients also have cognitive impairments. So there may be speech and interventions needed to address communication, swallowing, as well as cognitive needs. So I'm just going to go through and show you a few photos of examples. So, it may be that we're starting with a patient, in bed. So again, using resistance bands, ideally, to be, that's an option for working on strength. We're always going to probably focus on trying to get the patient out of bed as a priority, but if there's limitations and why that cannot occur, you can definitely start exercise in the bed. Also, cycle ergometry. Again, you see the patient is actually able to cycle while supine with this bike. So in terms of progressive mobility, again, we want to get patients upright. So maybe that first mobility is sitting edge of bed. It may be, in someone who's quite weak, using a bed that allows progressive weight bearing, in a patient who's too weak to begin weight bearing on their own. So ADLs, In this picture, you have a patient who's brushing their hair while standing in a standing frame, assisted standing position. So getting benefits of two, and also putting on socks while sitting at the edge of the bed. So this is a patient who's standing. She's actually boxing using the interactive video game while she has an endotracheal tube in place and on mechanical ventilation. And again, walking activities. This to me becomes one of the hallmark things I think is very critical, important, and again, safe and feasible. You see patients here are up, moving, mobilizing with an endotracheal tube in place. You can consider even more endurance activities and more upright. This is just bringing in a stationary bike for a patient to do some continuous biking in her room while being mechanically ventilated through a trach. And then, even considering more balance activities, these are a little bit more, again, you see this patient's actually outside, so it took a little bit more coordination, but doing some sitting, dynamic sitting, as well as standing activities. So again, just all types of activities that have been done in the ICU with our patients and help to really foster their function and their mobility. So again, highlighting this again, how important it is, to focus on the functional tasks first, really the functional task specific tasks before integrating more restorative treatment. Optimize treatment strategies to include cognitive tasks as well, if you're able to do that. While you're doing a physical task, also asking, the patient to complete cognitive strategies may be beneficial given the known deficits there. And then the real highlight here is there needs to be care coordination and communication with the team. Obviously, for all this to occur, you saw the last picture of the patient outside. That took coordination between a respiratory therapist, nurse, therapist as well to allow that to happen. But just to optimize treatment for patients to be medically ready, that is really important as well. So it's also really important that we're using consistent and valid objective measures. There's a list here. These are recommended measures for our intensive care patients, as well as patients we're following up post-intensive care. This would be the functional status score for the intensive care unit is a validated measure for measuring functional mobility and ability in the intensive care unit. Our manual muscle testing and MRC scores to address strength. Hand grip dynamometry also to address strength, 6-minute walk testing, 4-meter walk test as well, timed up and go, and the CATS independence, index of independence. These are all just measures that would be recommended ones for this population. So looking at the rehab progression after intensive care, the emphasis should still remain on functional training with focus on mobility and activities of daily living and instrumental activities of daily living. Once functional mobility and tasks have been addressed, you can then focus on more of the restorative measures such as strength and endurance training. For strength training, this can be really performed in many formats. But training in the 70 to 80% of one rep max is consideration, as well as considering circuit training or high intensity interval training as appropriate for patients. Again, so for endurance training, really should be performed ideally at 50 to 70% of heart rate reserve, with Borg scores of breathlessness in the 3 to 4 range. In addition, training measures for balance should also be considered. And patients really should receive education on individual home exercise programs, but just be aware that due to cognitive as well as health literacy concerns, we may need to consider multiple formats in which we're providing our education to our patients. So titration of exercise interventions, really we want to achieve overload principle while balancing the physiologic demand. So it really is an individual, plan for each patient in terms of doing objective measures and assessment of their exercise capacity and strength, and then tailoring the interventions to meet those needs and to not exceed the demands. I also think it's important, especially as an outpatient therapist, that we are screening our patients about ICU care. So any of our patients that have been in the hospital, I think it's really important to delve in and ask, were you in the intensive care unit? Were you on a mechanical ventilator? As well as, and if they have been in the ICU, I often tend to ask them just general screening questions around any mental health concerns or that they've had since the ICU as well. So that can help to warrant referrals to other providers as indicated. Another thing to consider is when we look at the domains of PICS that impairments that may impact other domains. So depression, if a patient has depression, that definitely will affect their physical function. If they have ICU-acquired weakness, we know that affects their quality of life. If they have cognitive impairments, this is going to affect their ability to perform at ADLs. So it really is crucial that our multidisciplinary communication is in place and that we have means to refer patients to other providers and that we're in communication with other providers as well. There are a number of challenges in rehabilitation management of post-intensive care syndrome. First, we really do not understand what the correct dose of rehab is. This includes, intensity, frequency, and duration, as well as the optimal type of rehab and delivery mode. There is no recognized clinical pathway as seen in CVA or MI to optimize care and coordination. And our rehab and post-ICU care is often fragmented with challenges in communication as a result. So I think, recognizing this and thinking of ways that we can optimize communication and collaboration with many disciplines is really crucial for these patients. So in summary, recovery from PICS is slow and may take months to years. Given the known evidence for safety and effectiveness for early ICU rehab, the continuum of care should continue long after hospital discharge in order to address known long-term impairments. And there really is this need for further research for the most effective rehab interventions to maximize function in our post-intensive care unit patients. Thank you so much.
Thank you, Dr. Jennifer Zaney, for your presentation on the physical impairment components of post-intensive care syndrome. Now I'd like to welcome Dr. Megan Hosey on cognitive and psychological aspects of post-intensive care syndrome. I'd like to remind you, please continue to submit those questions. We'll answer that at the end at a panel session. Also, you can continue to comment, retweet, or add comment at ICU Rehab or at Hopkins AMP. Again, thank you for joining us today, and I'd like to welcome Dr. Megan Hosey.
Hello, I'm Megan Hosey. I'm a rehabilitation psychologist at the Johns Hopkins School of Medicine. I'm here today to talk about cognitive and psychological aspects of post-intensive care syndrome. I have no disclosures. However, I would like to acknowledge the Parker B. Francis Fellowship Program, which does provide some financial support for my research. Today, we'd like to talk about ICU delirium, psychological experiences in the ICU and hospital, long-term cognitive impairment after intensive care, long-term psychological symptoms, and finally, some ideas about how to help. To properly frame ourselves in thinking about post-intensive care syndrome psychological symptoms, it's sometimes helpful to ground yourself in the patient's perspective. Imagine waking in an unfamiliar environment to strangers. You might be unsure of how you got there and where you are. You might have objects in each of your orifices, connected to lines and tubes. You can hear beeps and alarms, and maybe the laughter of others in unfamiliar conversation. Our ICU patient's environment includes being immobilized, being sedated deeply with drugs that change cognition. The environment might be included with limited stimulation. There might be reduced access to family and friends or people who can help you understand what's happening in your current situation. Many of our patients awake and tell us that they're not able to do anything for themselves. This goes to the basics of human function, including breathing independently, urinating and defecating independently, doing any basic hygiene, sleeping properly. They may be touched and moved without permission or without understanding about what's happening to them with limited discussion or preparation. And they might be experiencing physiological experiences like pain, breathlessness, thirst, overstimulation from lots happening in the environment, or again, understimulation without access to providers who routinely describe what's happening to them or family members. So, these experiences are the perfect recipe for an ICU phenomenon called delirium. Delirium is an experience with abrupt onset that can come on over days or hours, inattention, with inability to direct, sustain, or shift attention, decreased awareness of the environment, changes in the perception of what's happening, with some patients experiencing hallucinations and delusions, particularly those related to believing that nurses, doctors, and other providers are trying to harm them. And of note, many providers may confuse orientation with delirium. Today, we want to make it clear that a patient can be oriented to person, place, and time and still be completely delirious. Over the years, we've found that ICU delirium can happen in 20 to 80% of the hospitalized patients, with the highest propensity of delirious patients being in settings of mechanical ventilation. There are subtypes of delirium, including hyperactive, meaning increased agitation, anxiety, propensity to pull at lines and tubes, hypoactive delirium, where the patient is appearing sleepy, inattentive, and having decreased motor activity, or finally the most common type, where a patient switches between this hyperactive and hypoactive delirium. For our ICU patients, this can happen within about 2 days of admission. It can go on for an average of 4 days. And for patients with acute respiratory distress syndrome, 50% are delirious at some point in the ICU, and 10% continue to be delirious at hospital discharge, which can be very alarming for patients and for families as they transition to home. Just again, to touch base with the patient perspective, here are a couple of descriptions that our patients commonly provide. I would hear alarm bells, and that was my cue that I was going underwater again. I remember voices and knowing that I was drowning, and looking back and thinking about what I was told, this is probably when they were trying to take me off the vent. So here again, patients without a lot of context for what was happening with them, but having the perception they were drowning. After an ICU stay, we know that patients are at great risk for long-term cognitive impairments. The study of 821 patients published in the New England Journal of Medicine in 2013 revealed that delirium happened in 74% of the patients. And at 12 months, 34% of people had scores that were similar to patients who experienced traumatic brain injury. And a quarter of those patients had scores similar to those with mild Alzheimer's disease, suggesting that many patients are leaving the hospital with new cognitive impairment that will impair their ability to participate in everyday functions, things like return to work, driving, and participating meaningfully in their relationships. Risk factors for long-term cognitive impairment after an ICU stay include the things that are demonstrated here on this slide. The most common are sepsis, delirium in the ICU, and a longer duration of ICU delirium. There are other factors listed here that I won't read through to you, but you can see that long-term cognitive impairment is quite multifactorial. After an intensive care unit stay with acute respiratory distress syndrome, this study by Joe Bienvenu and colleagues reveals that 60% of patients had anxiety symptoms that were clinically relevant, 53% had depression, and 39% had PTSD during follow-up at 1 year. At 5 years of follow-up, 38%, 32%, and 23% had anxiety, depression, and PTSD, suggesting that these psychological symptoms can be very long-lasting. Notably, these psychological symptoms do not happen in a vacuum. They often co-occur with patients having more than one type requiring clinical follow-up. Risk factors for psychiatric problems after ARDS are demographic in nature. In this setting, women and people with lower socioeconomic status were at greater risk. People who have psychological symptoms before acute respiratory distress syndrome or an intensive care unit stay are more likely to be at risk for symptoms after. And people who had worse physical functioning prior to the intensive care unit stay and acute respiratory distress syndrome also had prolonged psychological symptoms. Notably, none of our studies to date find that critical illness or intensive care symptoms, like severity of illness, are associated with long-term psychological symptoms. This suggests that the severity of illness alone is not enough to predict long-term psychological health outcomes. So, what can we do to help protect patients from cognitive and psychological outcomes that are negative or impair function? The most ideal situation is that we have regular access to rehabilitation starting in the ICU and following the patient to home, long-term follow-up. In the intensive care unit, taking the time to do evidence-based care. That means lung protective ventilation and adhering to guidelines that protect against delirium, enhance sleep, and manage properly pain can help protect long-term outcomes. In the hospital setting, after ICU, medication reconciliation, education for patients and families about self-management and potential long-term consequences of ICU can help prepare them for the road ahead. And finally, at home, ensuring that patients have access to follow up with their primary care doctors, specialists, and intensive care recovery clinics could be helpful. Assessing long-term financial impact of intensive care after discharge can also be useful. Finally, ensuring that patients have access to ways to return to meaningful life activities like work and social engagement is important. Another thing to do to help is after discharge, providing a screening mechanism for these long-term outcomes to provide patients with education about their symptoms might include assessment with the IESR, the Hospital Anxiety and Depression Scale, and a measure called the EQ5D. Although these measures were validated for research purposes, we believe that they could also be helpful in educating patients and normalizing the post-intensive care syndrome. For patients who have concerns about cognitive outcomes, a screener with the MoCA instrument could also be helpful. Again, each of these measures has been validated in our intensive care post-intensive care syndrome setting. In conclusion, acute respiratory distress syndrome and intensive care are highly stressful occurrences for patients. Psychological and cognitive impairments are prevalent in these patients who are survivors. During and after hospitalization, routine assessment and ensuring access to adequate rehabilitation care can help patients regain function and access to meaningful lives.
Hi, everybody. Thank you for joining us for this presentation. We'll start the panel shortly. To start with, just so you know, we received numerous questions and there's just no way we're going to be able to get to everything. But please continue to submit questions because as we go through, we'll see those that are frequently asked questions and add those to our queue for the panelists. So to get off and going, I'll start down the list, and Dale, Jennifer, and Megan, off we go. To start with, do we have any data comparing pre and post initiation of PICS clinic in terms of return to work, functional mobility, etc.? And are there any studies on cost benefits of PICS clinics that we can use to support the need for a program? Dr. Needham?
Hi, thanks for that great question. Can you hear me okay?
Sure.
Great. So I think we need to have several parts to that question, but I'll try to be brief. This is a complicated question. In fact, we have an entire full day pre-conference in November dedicated purely to ICU follow-up clinics. And of course, there'll be some COVID-19 mixed into that. We've had lots and lots of questions around it. So it's a long, complicated answer. And there'll be lots of different perspectives. Each center that has a follow-up clinic does things differently, and it may depend what local expertise they have in terms of how much physical therapy or occupational speech or psychology or cognition's involved, social work, pharmacy. So things vary. In terms of, I think most of the question was focused around evidence. So we need to recognize this is a very, very new intervention in many hospitals. There have been randomized controlled trials, for example, of nurse-led follow-up done in the UK that absolutely showed no difference in outcomes between those patients that receive follow-up and those that haven't. Within the United States, this is newer than, for example, in the UK. And to date, there's only a single randomized controlled trial done from Vanderbilt University that has a lot of experience with doing this, and our speakers at our pre-conference in November. And I think they believe that there are strong benefits, but in terms of randomized controlled trial evidence, it's still at a pretty immature stage. So we're still learning, and I think it would be tough to take an administrator a randomized trial showing that there's benefit, and even business cases might be a little bit more difficult, but each hospital has their own approach to business cases, what kind of information is needed. And for example, in November, you'll have a chance to hear from what's happening at Johns Hopkins, what's happening at Vanderbilt, what's happening at many other centers, and each one of them's had a different approach. So I don't intend for that to be such a vague response, but there is a lot of information that's not yet known. And I do want us to be humble before we're advocating saying this is a strong evidence-based intervention, because it's not. We're at an early stage. There's many places that are doing early adoption. And second of all, I think given the huge number of survivors of severe ARDS due to COVID, so we need to put that in perspective, right? In the entire history of critical care medicine, there has never, ever been this many patients with severe ARDS, nor this many survivors of severe ARDS. So I think all health systems are being pushed to think about things and how to handle a big influx, especially if there isn't the same traditional access to rehabilitation after the ICU. So lots of people are innovating, lots of centers are innovating and learning how they go. So I do think that that's why we actually decided to have an entire day on this, so we could bring together experts from across the US to discuss this in an interactive way. So that's just the tip of the iceberg with that. Thank you for forwarding that, Mike.
And I just want to add on to what Dr. Needham said in one way, which is this, is while the jury is still out on distinct evidence, I think there are generalizable cases, and the case that's most generalizable, I think, for us to think about is frailty in geriatrics and post-hospital syndrome and the effect of post-hospital on geriatric patients and the effect on multiple systems and long-term impairment. So some of these things, when we're developing clinics and you're going to your hospital organization, all the time, all the evidence won't be there yet, but there's good reason to start pushing forward some foundations. And I think that's why we feel comfortable doing this presentation today, is although all the answers aren't there, we know these are important things to start to put the foundations forward and at least have some approach to addressing these impairments. I wanted to share on the screen, you can see this information, as Dr. Needham mentioned, is, we gave a brief 1 hour here on what is a full day at our conference. For resources, you can look at our conference, which will now be virtual, on November 5th through 7th, with access to material both prior to and after that date, as well as you can contact Hopkins AMP if your organization needs support in any ICU rehab or interdisciplinary activity and mobility promotion efforts around education and training and implementation. We'll leave that slide up there through the Q&A, and feel free to send all emails to the Hopkins AMP email address at the bottom. I'm going to hit the next question here. What is the presence of speech pathology services during early intervention, and was there a follow-up process for continued speech pathology services? We find the focus is always PT and OT on discharge, but speech services are often forgotten. So I want to tell you, we 1000% are with you. Speech is a hugely important part of our early rehabilitation program as well as follow-up. We know that different practices and where people cross over in cognition, communication might be different for different disciplines, but swallow, especially with prolonged mechanical ventilation, is really important and a component that we address early and often with speech, as well as in follow-up and recognizing diet changes and progression of care throughout the hospital. I'm going to hand it over, maybe if the rest of the panel would want to comment on anything I may miss on the role of speech as it interplays with the different items you all provide as physical therapists, psychologists, and Dr. Needham as the medical director.
I guess I would just comment as a physical therapist, in an ideal world,
our patients coming out of the hospital, if they have speech needs, are getting those referrals to the home care as well as outpatient. But I know that doesn't always happen in our system. So as a physical therapist, that is something I do screen for a bit in our evaluation, so that I can make that referral to our speech providers.
Thank you, Jen.
And I could also comment a little bit on, sorry.
No problem, Megan.
So in the intensive care unit, I find that collaboration with our speech language pathologist is invaluable. So not only are our speech language pathologists helping people getting back to swallowing and eating, they are so helpful in detecting changes in cognitive function. So often our SLPs are among the first people to diagnose and attend to delirium. By way of case example, yesterday, Therese Cole is one of our speech language pathologists who reached out to me to help me understand that one of our current inpatients was having delirium, particularly kicked off by having his television on. It was on the news with current events, and the current events blended with this patient's cognitive impairments to result in some pretty severe and troubling delusions, for example. In addition, they give me insight about other physiological symptoms that are distressing. So often our speech language pathologists are the first people to identify severe thirst as a major stressor for some of our patients. And then both the medical team and the rest of the team can begin to help address some of these other symptoms that are getting in the way of the patient's engagement in their rehab therapies and their medical interventions. They're invaluable.
Megan, I think we're going to stick with you here. Is there a role for patient diaries to be written retrospectively for survivors, as many units are not able to write patient diaries during the pandemic? And just so you know, we are getting a lot of questions around COVID-19 and the pandemic. We will discuss it in terms of the pandemic, but also outside of some of the restrictions we're facing. Megan?
So just to give everybody context, ICU diaries are one of the interventions that are, there's suggestion that they can reduce symptoms of post-traumatic stress disorder for patients who survive. They do give patients excellent context for their their intensive care unit stays. I do not know about the use of retrospective diaries, but I can tell you that currently one of the predominant stressors for our patients who are in intensive care unit for 2 to 3 weeks as they recover from COVID, for example, are telling me that what is difficult is A, not remembering large portions of their stay, B, feeling extremely vulnerable during that time, and C, the parts of the stay they do remember might include really severe or distressing delusions. And so what I would say is, if in the hospital, if you're working with rehab patients and coming up with something like a memory book or tapping a medical provider who has the time to start piecing together the intensive care unit stay as the patient's asking about it, again, I would just put that little note in. If the patient's not asking for a lot of detail, it might not be the best thing to jump in with it. But if they're asking and saying they're distressed, it might be a good thing to do. But as Dr. Needham says, we're very early with a lot of this information. And so we want to stay humble about it and maybe follow the patient's lead in some of these cases.
Thank you, Megan. Next one is, how about the nursing role in AMP, or activity and mobility promotion? It would be great to include this in the multidisciplinary program. And so we, again, I do this a bunch, we 1000% agree, and we have a program in place that we recognize that nursing is with the patient the longest throughout the day. And engaging patients in mobility, and really specifically ADLs, which are mobility with a purpose, is really important. We do that at Johns Hopkins using the AMP program in a systematic fashion, where the goal is for every patient every day to have a mobility goal as part of their care plan. And we do have a systematic approach to education and training and functional assessment by our nursing team. The goal is for nursing, along with rehabilitation, to drive mobility interventions, supported by the physician group in making sure that the expectation is understood by the patient and the family, as well as helping medically manage any barriers to mobility. So nursing drives a large number of the interventions, and also with regards to delirium and some of these other pieces can play a tremendous role in orienting the patient to time and space with simple things like being upright for meals, or recognizing the day-night orientation of time. So that's where we fit in the nurse role. The rest of the panel, do you want to mention anything else about roles of nursing beyond AMP, but really in PICS as well?
I love our nurses. Go ahead.
Yeah, I mean, I'll just jump in. I mean, I just, you know, since a lot of in the prevention of PICS is that early ICU mobility and activity piece, I mean, it really becomes crucial because it's just, you know, it's not something a PT or an OT, you know, can just go in and do individually on their own. There's that whole care coordination. So, I mean, it's, yeah, vital to have that, you know, communication and collaboration.
Okay, I'm going to Dr. Needham answer this one. This is actually just a procedural question. Can international nursing candidates present their research paper at the 9th ICU Rehab Conference? I'm going to go ahead and say yes, but Dale, I know you're going to probably provide more information on that.
We are so in sync. I was in the middle of typing an answer to that question. So I've sent a reply out to everybody with the website. So you can go to the website that I've just sent out and download the abstract form yourself. Anyone is invited to submit an abstract that will be refereed for either a virtual poster presentation or a virtual oral presentation. The deadline for abstracts is June 30th, so we're only less than a month away. And we, on November 5th, the day of the pre-conferences and the foundations, we have special abstract and poster presentations on that day. If you're specifically interested in doing work with ICU follow-up clinics, we have posters dedicated to ICU follow-up clinics and posters dedicated to activity and mobility promotion across the entire hospital. Both of those are abstracts on November 5th. So go to the website that I just sent out and download. And of course, at the bottom of your screen, there's an email address. If we say a website and you don't know which website we mean, you can email to the hopkinsamp@jhmi.edu and we can send you the exact URL if you can't find that.
So I'm going to hit a little COVID question here for you, Dr. Needham. What do we know so far about PICS in COVID-19 patients? I suppose there is no research yet, but have you noticed differences with other ICU patients?
Sure. So there isn't. We can't have 6-month outcomes of PICS patients when PICS didn't even arrive in the United States 6 months ago. So I think we all need to be humble. Lots of people are putting forward lots of hypotheses, but in terms of published empirical data, particularly from North America, there's little or none. There is some landmark work with the SARS coronavirus that was in Toronto. Probably one of the best papers published was done by an author. Her last name is Tansey, T-A-N-S-E-Y, published in, I think it was Annals of Internal Medicine, I think. Or Archives of Internal Medicine, that looked at outcomes. And the outcomes there, that was a very unique cohort because lots of the people were previously healthy. About 2/3 of the cohort were healthcare providers that got infected as part of delivering healthcare. So they had some unique situations. But I think many of us are expecting that all of the content that we're presenting is going to be highly relevant to COVID. The biggest difference is going to be that there's going to be so many more of these ARDS survivors than we ever in the history of critical care have ever encountered before. So what might have been a rare event before now might be common simply because there's not a greater proportion of patients with it, but there's a greater absolute number. So some findings may actually be quite amplified. Of course, there are some unique things or things that are more common with COVID, I think that we're seeing many more patients with severe ARDS, and some of these patients are requiring deep sedation. Some of them are requiring prone positioning. Some of them are requiring neuromuscular blockers. So as a result, and prolonged periods of mechanical ventilation. So the severity and duration of delirium, the severity and duration of bed rest are all higher, which we know will put patients at greater risk of physical, cognitive, and mental health impairments. So we also know that this is happening in a setting where family members at most hospitals are not permitted in. So we don't have that reassuring and reorientation that's happening from family members. We've got patients that are very frightened. We have healthcare providers who have to don PPE with each access to patients, which may decrease the frequency and the duration of healthcare providers' contacts. So it is a very, very scary time and a huge number of patients. And we hope that many people will be empirically studying both interventions and outcomes over the coming months.
I have a question here. It's more a statement, but I'm happy to answer. It says, please consider adding nursing to your presentation panel in the future. And I'll let you know, we would love, and we would add everyone to these panels. The problem is it turns into a multi-hour presentation, which is exactly what we're going to be doing in the fall. And in fact, if you look at the brochure, there are a ton of nurse presentations during that presentation and also in our usual spring conference. As a little bit of a teaser, Eleni Flanagan, who is a ICU nurse by training and currently assistant director of medical nursing for Johns Hopkins, will be doing a webinar, I'd say in the next couple months, on activity mobility promotion and our experience during COVID-19 and what does that help us for learning for the future. So I think that's exactly what you're asking for, and we will have that soon coming out to you. So, I know we heard that on speech as well. So I just want to make sure we emphasized how important we think the entire multi-D team is. And I'm going to say respiratory therapy is also a group that we know are big partners here.
Yeah, each one of these webinars isn't trying to replace the full 3 days of our annual conference. We have to curate content. We have to curate speakers. People have to take time out of their schedules to do this. You know, we only asked Jen and Megan a couple of weeks ago to do this. So we have to sample. There, again, at their website, there's a series of prior webinars that have been done. Each of them have different cross sections of people who are involved. One of them is a pediatric intensivist, you know, that you don't see here. There's no content about pediatrics right now. We do have strong input of nursing, speech, occupational therapists, but we only can put so much into 1 hour of content and 30 minutes of Q&A. And we need to recognize that people are spending huge amounts of time at the bedside, and we have to be careful about how much time we're taking away from people's bedside activity, given that, as I said again, we've never had this much severe critical illness, and there's a huge surge that all of us are trying to manage. So we need to be respectful of the time that we take away from bedside care.
Please, though, continue either via email or these questions. If there are components, disciplines, perspectives you'd like to hear about, please send them our way. That is literally how we determine what the next topics and contents will be. Next question. When do you initially assess with PICS? Is it in the ICU or when transferred to the ward? So I'm going to give you a quick one, and I'm going to say we do this for everything, which is, and I learned this mostly from cancer survivorship, is diagnosis and the plan for survivorship starts at the point of diagnosis or the point of admission. I appreciate the picture becomes clearer as time goes on, but we're a pretty proactive group. Dr. Nita, Megan, Jen, how would you add on to that?
So I'm going to jump in just so that everybody's using this term PICS correctly. This isn't a diagnosis. So about 10 years ago, myself and a multidisciplinary team with official representatives from the American Physical Therapy Association, OT Association, Speech, Language, Hearing, Physiatry, Social Work, all sorts of a large multidisciplinary group was gathered together by the Society of Critical Care Medicine. Out of that meeting about 10 years ago, we came up with the term post-intensive care syndrome, not to be a diagnosis, not to be the focus of scientific research. You can't diagnose PICS, you can't measure PICS. We created this to raise awareness among ICU people, awareness among outpatient doctors, nurses, and healthcare providers, awareness among patients and families, because most people did not understand that you could spend a few days in the intensive care unit, go in with a lung problem, and come out with a brain, muscle, and nerve problem. So it was really done to raise awareness and education rather than something that should be scientifically measured or diagnosed. Of course, we can screen for cognitive impairments, psychological impairments, and physical impairments, but you're screening for those exact things. You're screening for muscle weakness or impaired physical function or depressive symptoms. You're not screening for PICS. I do not encourage people to try to think of it in that sort of paradigm. That's absolutely not our intention when we created this. And if you go back to the original papers, you'll see that what our intention was.
Dr. Needham, with regards to those screening for those impairments, we're doing that early, often at transitions of care. I'm not using the word PICS on purpose here, but screening for those impairments. Could you maybe speak to that process as the patient
Sure,
goes
absolutely. It may not be as
continuum?
complicated as what people think. If your ICU, for example, is doing standardized sedation and delirium screening, tick. You've got cognition. That's the most relevant thing to do when patients are acutely ill. If you have nurses and PTs that are mobilizing patients and OTs, then all of a sudden you are getting measurements of weakness and function, especially if you're using a scale like the Johns Hopkins highest level mobility scale or the ICU mobility scale or the AMPAC tools. Those are ways that are going to give you reliable and valid screening measures of what's happening. And for example, in terms of speech, nurses or speech language pathologists may be doing bedside swallowing examinations, which again are a screening test for swallowing. So I think people may be doing this and not recognizing it. I think when ICU follow-up clinics are being created, there I think we're in a whole different realm and people are wanting surveys. Patients there may be able to do validated surveys at that stage, and they may be wanting surveys, and many ICU follow-up clinics do this, although there are not great evidence for what's best. But the end part of Dr. Hosey's presentation did hold people's hands and take them through some measures that an international panel has suggested are the best measures to use, at least for research purposes. And there's an entire website devoted to measurement for ICU patients and survivors. It's www.improvelto.com. Go there. There's an unlimited amount of resource and help, including results of this international consensus panel on screening and measurement.
Jennifer, I think this is for you, but it might extend outpatient therapy in PICS patients. And so I'm going to say physical therapy, but I also appreciate it could be other. It could be cognitive. It could be another of others. But let's go with physical therapy for now. Do you recommend long-term, low-frequency care or multiple episodes of care given the duration of symptoms?
A good question. I think that, I would like to see, I always like to see patients as soon as I can when they're appropriate for outpatient, whether that means when they're leaving the hospital or they're coming out of home care. So I kind of approach it more from the, let's try to do things a little bit more intensive for a period of time, rather than multiple periods of care, but just try to really optimize, a little bit more that higher frequency to the point where they're independent with doing more of a home exercise management program rather than, trying to deal with multiple episodes of care.
In addition to cognitive components to ADLs and IADLs, are there any cognitive rehabilitation strategies or tasks recommended? I understand we don't have an OT or speech who does a lot of this in some of our programs, but maybe our panels can talk to what they do and where you all cross over from an interdisciplinary perspective with regards to cognitive components of care.
So I would say that from a cognitive perspective, the number one thing that we can do for cognitive rehab starting in the intensive care unit is adopt the framework that Mike was just talking about and start thinking about survivorship. The number one best thing that patients often tell us is figure out who I am, what I was doing at baseline, who was important to me, and start integrating that into my care immediately. So from a cognitive perspective, I would say before we go to any functional tasks, that might be the number one best thing we can do for our patients, is to help them maintain their sense of self early in the intensive care unit. As you progress through inpatient rehab and then to home, each specialization will do different types of cognitive rehab that are likely embedded in their care. I know Jen can speak to some of the cognitive components that she adds to PT on the outpatient side, but that's what I would sort of say early and often is catch your low-hanging fruit, figure out who this person was at baseline and what would make them feel like the most themselves right here in the moment. And then also I know Dr. Needham has updated information about what our OTs are doing for their cognitive stimulation protocol in the intensive care unit as well. That might be a more specific intervention with a little bit of data coming from our colleagues in South America that we're trying to update at Hopkins. Is that right, Dale?
Sure, that's correct. So a big shout out to Evelyn Alvarez, who's an occupational therapist at University of Chile, and her with a group of people led a randomized controlled trial of an OT-based cognitive stimulation intervention that also involved functional activity in Chile and showed a dramatic decrease in delirium in critically ill patients that were not mechanically ventilated with a relatively lower severity of illness. And Dr. Alvarez has really inspired us to think about how we can do more cognitive stimulation as part of regular care, led primarily by our nurses, but also more by our occupational therapists as well. So that's sort of a work in progress that we're doing as well. Thanks, Dr. Lizzie. And unfortunately, I think we have to watch the time. We're already slid past 1 o'clock.
Okay, I'm going to take one last question here. One of the problems in my ICU, patients are not willing to be mobilized, and even when physiological parameters are within optimum range. And sometimes the family also believe being critically ill means rest, not to be disturbed. Is this common? And yes, and how is it addressed? And it's very common. We get this all the time, patient refusal, and this really is a multi-pronged approach. We address this through our activity mobility promotion program. It really starts with setting the expectation for the family and the patient that mobility is part of care, no different than medications. It includes having goals of care per the day, just like they have other elements brought from the interdisciplinary team, just not one provider. Also, we have a formal program that we do called patient engagement, and we train people on how to, as a provider or a clinician, have a conversation with a patient to get past refusals, not just to mobility, but to a number of things in their own healthcare. So you bring up a really critical challenge, which is this concept of sickness or illness mentality, and really our ability to engage people in their own healthcare. And this is an important component. I'll say we had a ton more questions that we just couldn't get to. What we will try to do is put these out and some answers to them as FAQs. If you have additional questions, please hit us up at the hopkinsamp@jhmi.edu email. As you can see on the screen here, we hit about an hour and a half of content here with number of questions with other disciplines and across the continuum of care. We really hope to target that in November, as well as if your institution is looking to implement any of the programs, whether it be ICU rehab, across the hospital mobility program, or are starting to think about post-intensive care, reach out to us about how we can support training and implementation. We really look forward to seeing you soon. Keep an eye out on social media for upcoming webinars that really we plan them very quickly as the need arise. But as you can see, I think with about 96 hours of content, we had close to 800 people register for today. So thank you for your participation, and thank you for everything you're doing out there to treat and optimize the care of ICU patients and ICU survivors. Dr. Needham, is there anything you'd add?
No, I think that was great. This is just the best that we could put together. We know that there's a great amount of interest and wanted to begin to get some content available, as well as a whole list of other resources. As Michael said, we're never going to be able to relay all of this in 90 minutes or in 3 days, which is why we've tried to emphasize in the webinar all the different resources that are out there, and some of them highlighted on this slide. You know, as I've been typing responses to everybody, this webinar has been recorded. It will be posted at the website. You and your colleagues can go back and look at it. You don't have to have registered for the webinar to look at it. You can go back and look at it and scroll through to find some of the resources or questions. Also, our email address is there for questions that we weren't able to answer. Please reach out to us. We will do our best to reply, but recognize that we all are doing clinical care and very, very busy, and sometimes it's a huge volume of questions. We will do our very best as we can, while we're also balancing clinical duties and research as well. So everybody, please be safe. This is a very challenging time for yourself, your families, your patients and their families. So, but we're going to have a profound impact during the stress of COVID on our patients and outcomes. And all of this learning is incredibly important.
Thank you all. And everyone have a wonderful rest of the day. Bye-bye.